different neurodegenerative scenarios. The first involving the hippocampus and the cortex, and we discussed dementia. The second involving the basal ganglia, and as we have discussed, the Parkinson disease and Huntington disease. And today we will discuss those neurodegenerative disorders involving the cerebellum and its connections, leading to the clinical scenario of or the clinical presentation of ataxia. We have different types of ataxia, spinocerebellar ataxia, and Friedreich ataxia, and ataxia telangiectasia. First, what do we mean by ataxia? Ataxia is a clinical manifestation, so it's not a disease by itself, it's a symptom, and we have to know what is the cause of ataxia. It results from a poor muscle control, leading to clumsy movements. It can affect walking and gait, can affect balance, the hand coordination, speech and swallowing coordination, and eye movements. So most of the time, ataxia deals with the coordination of movements, and the part of brain that is responsible for this coordination is the cerebellum or its connections to the brain or the brainstem, the thalamus, and the spinal cord. That's why sometimes it's called spinocerebellar ataxia. The ataxia is divided clinically into sensory ataxia and cerebellar ataxia, depending on whether the ataxia depends on the sensory input to the body. So in sensory ataxia, for example, the patient will lose the coordination or the control when he closes his eyes and stops the visual input. However, in cerebellar ataxia, the ataxia is not affected by whether the patient is opening or closing his eyes. So ataxia, as I said, it's a clinical manifestation indicating a dysfunction of the parts of the nervous system that coordinates the movement. The site of control is the cerebellum with its connections to other central nervous system parts, in addition to the problems sometimes in the neuromuscular junction itself. It is part of the neurodegenerative diseases, and it is characterized by different manifestations like lack of coordination, whether while walking, while movements, while sometimes in the speech, eye movement abnormalities, which we call it nystagmus, and slurred speech, problem with swallowing and coordination of swallowing, sometimes resulting in heart problems, a tremor and the deterioration of fine motor skills, gait abnormalities. In those patients, they have difficulty in walking and maintaining a coordinated gait, sometimes resulting in a wide-based gait. So the symptoms of ataxic gait, this is the most important manifestation of ataxia, is the ataxic gait, lack of proper coordination, unsteady gait with the potential to stumble and fall, frequent falling episodes, and lack of muscle coordination in the legs with ambulation difficulties. The diagnostic tests that the doctor uses to diagnose ataxia are different. We have the finger-to-nose test, the shin-to-heel test, and the Romberg's test. The finger-to-nose test, when you ask the patient to reach for your finger with an outstretched arm with his hand, and then touches their own nose, and repeat this process several times. Patients with ataxia, they will find it difficult to maintain this high level of coordination. The shin-to-heel test also, it's the same. When you ask the patient to repeat the movement of sliding the heel of their foot over the shin also for several times. And the Romberg test, in which you ask the patient to maintain an erect posture with his eyes closed. This is important to differentiate between a sensory ataxia and a cerebellar ataxia, because the presence of near normal coordination in the movement is visually observed by the patient as characteristic for sensory ataxia. So we will start with spinocerebellar ataxia. It's a heterogeneous group. It's like an umbrella under which we have so many types of ataxia. Like Friedreich ataxia is considered a subtype of spinocerebellar ataxia. It's a group of diseases characterized by cerebellar ataxia, sometimes sensory ataxia, spasticity of the muscles, and sensory motor peripheral neuropathy. They differ in the causative mutations and the patterns of inheritance, the age of onset, and signs and symptoms. They affect the cerebellar cortex, the spinal cord, and other brain regions and the peripheral nerves variably. We have several forms of spinocerebellar ataxia, as I said, and some of them are caused by the CAG repeat expansion, like that we discussed in Huntington disease, causing an intranuclear protein inclusions, among other different mutations. So let's start with Friedreich ataxia, which is the most important spinocerebellar ataxia, and it is inherited as an autosomal recessive pattern. It is usually presented in the first decade of life, so it affects children. The patient presents with a gait ataxia, followed by hand clumsiness and dysarthria, in which they have difficulty in articulating their words and speech. There are some other associated features for Friedreich ataxia, like piscavus and kyphoscoliosis, and there is a high incidence of cardiac diseases and diabetes in these patients. So this is the piscavus that is associated with Friedreich ataxia. It is a high curve in the foot compared to the normal arch of the normal people. So here we have a high arch in patients with Friedreich ataxia. And those patients also, they have kyphoscoliosis, in which there is an abnormal curve and also lateral curving of the vertebral column. Mutations in Friedreich ataxia are the GAA trinucleotide repeat expansion. We said that not all spinocerebellar ataxia, they have the CAG repeats. We have other mutations that characterizes these different types of spinocerebellar ataxias. The GAA, it's a normally present protein. However, it's expanded in patients with the Friedreich ataxia. It codes for a frataxin protein that regulates the mitochondrial iron metabolism. The repeat expansion leads to silencing of the transcription of this trinucleotide repeat, therefore decreasing the level of frataxin and mitochondrial dysfunction. This will lead to oxidative damage of the cell and loss of the neurons. So the damage here, it's not caused by the protein deposition as in other neurodegenerative diseases, rather by the loss of the frataxin protein leading to neuronal loss. Another disease is called ataxia telangiectasia, in which it is characterized by cerebellar ataxia and oculocutaneous telangiectasias, in which you find dilated vascular blood vessels at vascular spaces, mostly in the eye, sclera, and in the skin. Those patients also, they have immunodeficiency, genomic instability, leading to higher sensitivity to ionizing radiation and predisposition to malignancy. So this is the telangiectasia, as I said, it's dilated blood vessels. أكتر شيء ممكن نشوفهم في بياض العين, the sclera of the eye. Also, they can be seen in the skin. And these patients, they are characterized by the presence of cerebellar atrophy because of the neuronal death in the cerebellum, leading to ataxia. The last neurodegenerative disease involves the motor system, leading to difficulty in swallowing and respiration with muscle weakness. And the most important example is the amyotrophic lateral sclerosis. So here the degeneration occurs in the part that regulates the motor system in the brain and the spinal cord. So amyotrophic lateral sclerosis leads to death of the lower motor neurons in the spinal cord or the and the brainstem or the upper motor neurons in the motor cortex or both of them. The loss of the lower motor neurons results in a clinical manifestations that is different from upper motor neuronal loss. The lower motor neuron loss leads to denervation of the muscles, leading to muscular atrophy. That's why it's called amyotrophy. And weakness of the muscles with fasciculations, that is involuntary contractions of the groups of muscles. The upper motor neuron disease results in paresis, its paralysis, hyperreflexia, and spasticity, بدل weakness, along with a positive Babinski sign. This is the positive Babinski sign when you slide with the hammer along the lateral side of the foot of the patient, the sole of the foot. A negative test leads to flexion of movement of the toes. However, a positive test leads to hyperextension movement of the toes, indicating that there is an upper motor neuron problem. The upper motor neuronal loss leads to degeneration of the corticospinal tracts in the lateral portion of the spinal cord, leading to lateral sclerosis and hardening of these areas. That's why it is called sclerosis, amyotrophic lateral sclerosis. The sensation in these patients is usually not affected, but cognition impairment can be there. There is a male predominance and amyotrophic lateral sclerosis, and it usually appears in the fifth decade of life and after. The pathogenesis, most of the cases are sporadic, 10% are familial, inherited as an autosomal dominant pattern, and they are characterized by early onset of the disease. The mutation is in the superoxide dismutase gene SOD1 on chromosome 21, and this generates abnormal misfolded protein, which triggers the unfolded protein response in the cells and leading to apoptotic loss of these neurons. Other mutations can occur, like hexanucleotide repeat expansion of C9orf72, and sometimes they can be mutations in the TDP43, which we have discussed in the frontotemporal lobar dementia, and in the FUS gene. There is an overlap sometimes with the frontotemporal lobar dementia due to the same inherited protein mutation and deposition. The symptoms begin with subtle asymmetric distal extremity weakness, leading with progression of the disease, the muscle strength and the muscle bulk diminish, and involuntary contractions to individual group of muscles leading to fasciculations can be seen. Eventually involves the respiratory muscles, leading to recurrent bouts of aspiration and pulmonary infection, which is the usual cause of death in these patients. Most patients exhibit both upper and lower motor neuron disease. We have a special type of amyotrophic lateral sclerosis called bulbar amyotrophic lateral sclerosis because of the degeneration of the lower brainstem cranial motor nuclei. So it is characteristically affect the cranial motor nerve nuclei, leading to abnormalities in the swallowing and the speaking, which predominates the picture in these patients. Morphologically, macroscopically, the anterior roots of the spinal cord are so much thin and gray in color. This is the most striking feature that we see macroscopically. In severe cases, they may have atrophy of the precentral gyrus, which is the motor cortex due to the loss of the neurons. Microscopically, the most important finding is the reduction in the number of the anterior horn motor neurons throughout the spinal cord associated with reactive gliosis and loss of the anterior root myelinated fibers. The similar changes can occur also if the cranial nerve nuclei are affected. But there is a characteristic sparing of those that supplying the extraocular muscles. In the disease that is characterized by TDP43 mutations, we might find cytoplasmic inclusions of this protein. The skeletal muscles, if you take a biopsy of them, they will show neurogenic atrophy due to the loss of innervation. And this is the normal muscle, and see how the muscles in amyotrophic lateral sclerosis are so much atrophied and thinned. Look at the normal nerve roots that came out from the spinal cord, and look at the nerve roots in amyotrophic lateral sclerosis in which they are thinned and atrophied. This is the most striking feature. You can see here the diagrammatic presentation. These blue dots imply the anterior horn motor neurons, and they are lost in amyotrophic lateral sclerosis in this picture to the right. The lateral columns of the spinal cord show much sclerosis and hardening, and this is the characteristic feature of amyotrophic lateral sclerosis. This table summarizes all the neurodegenerative disorders which we have discussed so far, and it's important to know the clinical pattern and the protein inclusion if it is there. By now, we have finished the neurodegenerative disorders, and we move to acquired metabolic and toxic disturbances because they are a common cause of neurological manifestations, because the brain is particularly vulnerable because of its high metabolic demands. So any deviation from normal in its oxygen supply, glucose supply, toxic materials can result in many clinical manifestations. So we will start with nutritional diseases, the thiamine deficiency, which usually results from chronic alcoholism or patients with gastric disorders or gastric bypass and vomiting to this deficiency. The systemic manifestations of this problem is called bleeding. However, the brain manifestations are called Wernicke encephalopathy. The encephalopathy is characterized by abrupt onset of confusion, sudden onset, in addition to ataxia and abnormalities in eye movement like nystagmus. The treatment is thiamine, and it will reverse the deficits immediately. However, delayed treatment leads to irreversible, profound memory disturbances, which we call it Korsakoff syndrome. The combination of the acute manifestations, which we call it the Wernicke, and the delayed manifestations of memory disturbances is called the Wernicke-Korsakoff syndrome. So the immediate treatment is very important in those patients. Morphologically, the most important finding is the hemorrhage and necrosis in the mammillary bodies, and which are adjacent to the third and fourth ventricles. Later on, there will be cystic spaces with hemosiderin-laden macrophages microscopically seen. The medial dorsal nucleus of the thalamus lesions best correlates with the memory disturbance in Korsakoff syndrome. And these are the mammillary bodies. Okay. And these are the hemorrhage and necrotic areas and black discoloration. The second nutritional deficiency is the vitamin B12 deficiency, which causes a type of anemia. We call it pernicious anemia, characterized by the presence of neurological manifestations. Subacute combined degeneration of the spinal cord is the main clinical scenario or syndrome. It affects the ascending and the descending tracts in the spinal cord. The symptoms usually develops over weeks, so it's not a sudden onset. The early clinical signs may be associated with mild ataxia, lower extremity numbness and tingling sensation, and this is commonly described by the patients. Sometimes it can progress to spastic weakness of the lower extremities in severe cases, and sometimes to complete paraplegia. If the patient develops complete paraplegia, the outcome is poor despite the treatment. The treatment is usually easy, and it is a vitamin B12 supplementation, which leads to the reversal of the neurological manifestations as well as the anemia manifestations. Um, Second, we have metabolic disorders that can affect the brain, like hypoglycemia and sometimes the hyperglycemia also. The hypoglycemia effect resembles those of global hypoxia or anoxia because oxygen and glucose are required for by the brain to perform its function. Glucose is considered the main or the only energy substrate in the brain. Hippocampal neurons are particularly susceptible to the decline in the glucose level. Cerebellar Purkinje cells are relatively spared. If level and duration of hypoglycemia are sufficiently severe, there will be a widespread injury in the brain. Who are the patients that are susceptible to hypoglycemia? Most of the time, they are diabetic patients who forget to who took an extra dose of their oral hypoglycemic medications or insulin medication. The hyperglycemia also it can lead to problems in the central nervous system, on the brain particularly. Those patients are usually uncontrolled diabetes mellitus patients, whether diabetic ketoacidosis like in type 1 diabetes or a hyperosmolar coma like in type 2 diabetes. The patients present with confusion and stupor, and eventually they might enter into a coma. Intracellular dehydration is the main mechanism that results in these manifestations due to the high osmolality of the blood. So the water content leaves the cells to the outside, leading to intracellular dehydration. The most important aspect here is that the rapid correction can produce severe cerebral edema. So we have to correct hyperglycemia gradually. The hepatic encephalopathy, it is a hepatic dysfunction leading to depressed levels of consciousness or sometimes coma. The early stages of hepatic encephalopathy are characterized by a flapping tremor. We call it asterixis, in which when you ask the patient to outstretch his hands, his arms, the hands start to make tremor movements, and this is characteristic findings in in patients with hepatic encephalopathy. The cause is the elevated levels of ammonia, leading to, in addition to the inflammation and the hyponatremia in patients with hepatic dysfunction. The ammonia metabolism occurs only in the astrocytes because they have the glutamine synthase, and accumulation of ammonia leads to the development of Alzheimer type 2 cells, which are defined as an astrocytes in the cortex and the basal ganglia with a swollen pale nuclei. Finally, we have the ethanol toxicity, which can be acute alcoholism or chronic alcoholism. Acute intoxication is reversible because of excessive intake, leads to profound metabolic disturbances, brain swelling, and death. However, the chronic alcoholism leads to cerebellar dysfunction. It accounts for 1% of cases, leading to atrophy in the anterior valgus of the cerebellum. This problem is characterized by ataxia because it involves the cerebellum, an unsteady gait, and nystagmus. And thank you.